You know that medicine in your cabinet? Ever stop and wonder how in the world it got there? I mean, it starts as just an idea in a lab and somehow ends up on a pharmacy shelf. Well, that's an epic story. And today, we're going to break down that whole journey.
It really all comes down to this one question, because it's not enough for a drug to just work. Before it can ever help a patient, it has to earn the right to be sold. And that means going through this incredibly formal, really demanding, and super high-stakes process.
And when I say journey, that is a serious understatement. We are talking about a marathon here, not a sprint. Think about that. A decade, sometimes even longer, of nonstop research and testing, all before a single doctor can prescribe it. And to get through this journey, you've got to learn a whole new language. It's this crazy alphabet soup of acronyms that looks, honestly, pretty intimidating. But don't worry, that's what we're here for, to make sense of it all.
Okay, so let's start at square one. Before you can even think about proving a drug works in people, you have to get permission to even try it in people. This is the very first massive gate you have to get through.
So, in the United States, that first permission slip is called an IND. It stands for Investigational New Drug Application. This is your first official handshake with the FDA, where you lay out all your cards, all the data from your lab work and animal studies.
Now hop across the pond to Europe and the UK, and they have their own version. It's called the CTA, or Clinical Trial Authorization. Does the exact same thing, just a different name for a different place.
Okay, now this is where it gets really interesting. Check out the difference in philosophy here. In the US, the IND works on this silence is golden idea. If the FDA doesn't get back to you in 30 days with a problem, you're good to go. You can start. But in Europe, nope. You have to wait for an active, explicit yes before you can do anything.
I love this analogy because it just makes so much sense. Let's pretend you've invented a new medicinal popcorn. Filing that IND isn't about proving it's the greatest, tastiest, most effective popcorn ever. No, it's just about showing the regulators that, based on all your initial tests, it seems safe enough to let a few people try it out. That's it.
All right, hit the fast forward button. Years, and I mean years, have gone by. You've run successful clinical trials with thousands of patients, and now you're standing in front of the final gate, the big one, getting permission to actually sell your medicine.
Back in the US, if your drug is a typical pill or injection, what scientists call a small molecule, you file an NDA, a new drug application. This thing is a monster. It's basically a massive digital binder with every single piece of data you have ever collected on this drug.
But what if your medicine isn't a simple chemical? What if it's something complex, like a vaccine or a gene therapy that comes from living cells? For those, which are called biologics, the FDA wants a BLA, a biologics license application. The process is pretty similar, but the section on manufacturing is way more intense because making a consistent product from living things is a huge challenge.
Over in Europe, they keep it a bit simpler. It doesn't matter if it's a small molecule pill or a complex biologic. You file one thing, the MAA, or Marketing Authorization Application. They don't split it up like the US does.
So this table kind of lays it all out nicely. You can see right there, the US splits things between NDAs for small molecules and BLAs for biologics. Europe, on the other hand, just uses the MMAA for everything. And take a look at the review times. The standard in the US is around 10 to 12 months, while Europe works on a 210-day active review clock.
And we're back to our medicinal popcorn. And guess what? The big trials were a smash hit. It works. So you bundle up every last piece of amazing data and you send it off to the regulators. An NDA to the FDA in the US and an MAA over to Europe, probably at the exact same time.
So you're probably thinking, how on earth do companies manage all these different applications for all these different countries? Sounds like a nightmare. Well, let me introduce you to the unsung hero of global drug approval. It's called the eCTD, which stands for Electronic Common Technical Document. The easiest way to think about it is like a standardized 5-drawer filing cabinet. Now, the absolute genius of the eCTD is that the really important stuff, the science in drawers 2 through 5, how it's made, the animal studies, the human studies, is organized the exact same way for every country. The only thing that changes is the paperwork in drawer 1. It was a total game changer.
This same bowl idea says it all, doesn't it? Before the eCTD, it was like you had to recook your popcorn data for every single country's specific tastes. Now, the recipe, the science, is organized just one time, in one standard bowl, and then you can serve it up everywhere. Truly a revolution for the industry. Okay, so we've met the key players, we know the acronyms, now let's zoom out and put all the puzzle pieces together to see the entire picture from start to finish.
And here it is, the full marathon. You've got years of just basic discovery work. Then around year 3, you file that first IND or CTA to get permission to test. Then you slog through 3 phases of clinical trials. Phase 1 is about safety, Phase 2 is about seeing if it works at all, and then the giant, expensive Phase 3 trials. It's only after all that, around year 11, that you're even ready to submit that final application.
And getting across that finish line, well, it comes with a pretty shocking price tag. Just to get the FDA to look at your application, companies have to pay a user fee, and right now that's about $4 million. Now, that money helps fund the FDA's reviewers, but just to be crystal clear, that's not for the research. That is just the price of admission for the final review.
But what about those really desperate situations? For serious diseases where patients just have no other options, are there any shortcuts? Well, kinda. Regulators have created what you can think of as fast lanes. A priority review can literally cut the FDA's review time in half. And a breakthrough therapy designation means the FDA is holding your hand and giving you advice the whole way through.
Now, this is maybe the single most important thing to understand about these faster pathways. Fast track does not mean less safe. It doesn't mean they're cutting corners. The scientific standards are exactly the same. What they do is compress the process, maybe reviewing data as it comes in instead of all at the end.
And that really brings us to the big, thorny question at the heart of all of this. This entire system, this decade-plus, billion-dollar journey, is designed from the ground up to ensure maximum safety for the public. But if you're a patient and you have no other options, is it fast enough? It's a really tough debate, with actual lives hanging in the balance.